just
tell me when we're live.
Yeah. Okay, stream is live. Good evening, everybody. We're just having some final checks here to make sure that you can hear us all. I hope you can hear us. So thank you for attending. Yes, we can hear. Fantastic. So my name is Dr. James Tran. I'm clinical coordinator for GDR, and we have a special guest tonight. He is Dr. Bez Shokouhi, who is a dentist in Sydney, and he's presenting today on the topic of Onlays, and on more so, Dr. Bez is one of our clinical educators for our general dental residency program. So he's been an integral part of the GDR program. So it's a lot of slides. It's quite jam-packed. If you have any questions, please pop it in the chat window on the right side, and we'll get to all the questions at the end. And I promise we will go through all the questions, no matter how many questions, and no matter how long it takes, whether it's 2 or 3 hours. Hopefully not that long, but we'll definitely get through it all. So the format will be around 45 minutes to an hour of the didactic, and we'll get to the questions at the end. So please have your questions at the end for us. I think we're ready to go. So if you're ready, Dr. Bez.
Thanks very much, James. Welcome, everyone. So I'm Dr. Bez Shokouhi, and we've got a lot to cover tonight. We're going to be talking about Onlays. Onlays Decoded, a no-nonsense guide for everyday practice. I just want to try to make this as useful and practical for everybody to be able to use, and hopefully go tomorrow to your practices and use some of the techniques and things that I've got here for you. So like I said, there's a lot to cover. Hopefully we'll be able to do it in 45 minutes to an hour, but let's have a bit of fun together. Okay. My crown has come off. Anybody else get that as a phone call? People call up and say my crown has come off, and I don't know about you guys, but in my experience, when patients call in with this advice, it's not always as clear as it sounds. So these are some photos that I've taken at some point. Patient comes in, and this is what they present to you. This is the crown on an upper premolar, and when you turn around and you have a look at it, this is what you see. So it's not just come off. What's actually happened? The tooth's decoronated. It's broken and is stuck inside the crown. The patient has no idea. They think it's going to be a straightforward, just sticking it back and gluing it back on, and everything's going to be okay. But we know that it's not that simple, because when you have a look in the patient's mouth, this is what you find. And the tooth's completely broken. There's no supragingival structure left. And a lot of the times, if a tooth is, in this kind of a state, there's not a lot you can do. And you've got to give the patient a bad news that we've got to take the tooth out and think of some sort of a replacement option. So, this is another tooth. This is an anterior tooth, another one of mine that I saw some time ago. This is a tooth 2-1, another decoronated tooth. And I think this is very common. Again, I'd be interested to see how many other people see this in practice. I've spoken to a lot of colleagues, and we see a lot of decoronated teeth. So why does this happen? Why do teeth, even though they've got crowns on, which is supposed to make them stronger and protect them against fracture, why are we seeing these broken, decoronated teeth that basically they failed so catastrophically that a lot of the times there's not a lot you can do for them except to remove them and replace them? A little bit about myself. So I'm Dr. Bez Shokouhi, and I hail from England, from London, which is where I grew up most of my life. And even though there are beautiful photos of Tower Bridge and Westminster that I showed you, this is a reality in London. It's often rainy and cold, and hence why I moved to Sydney, to Australia, to Sydney, to have a better weather, better lifestyle. I qualified in King's College London, which is a very good dental school. So very happy to have come from there. This is a little summary of my journey, my career journey. I qualified in 2006. And for the first few years, I did various hospital jobs in the UK. They're called senior house officer jobs or SHO jobs in various departments. I did a year of Max Fax, which was great fun, but it convinced me that I don't want to do surgery as a career. In 2011, I came to Sydney. 2014, for about a year and a half, I did a master's in aesthetic dentistry from King's College London. And in 2016, I did the University of Sydney oral implants diploma, which is a great program as well. As Dr. James mentioned, I have been running the GDR restorative workshop for a few years now, which is a great thing to be able to do. I've been a mentor for GDR, which I really enjoy. I do some mentoring and examining for the University of Sydney implants diploma as well. Okay, so let's carry on. This is our scenario. So we were going to talk about the cause of this. Got some diagrams for you. So let's have a look at this. So we've got a tooth here. That's the enamel shell. And let's look at a sort of a typical crown preparation. Let's say for a PFM or a full ceramic crown with, decent shoulders on there. And when you get your full coverage crown on there, this is what it looks like. It looks great. However, we don't go crowning teeth when they're virgin and sound the vast majority of the time. If we go back to our tooth, a lot of the times our tooth is heavily restored. There's a big restoration in there. There are crack lines in there. There's a lot of tooth missing. So if we imagine that's a amalgam or a composite in tooth, we've got pretty thin cusps there. Let's look at our crown prep again. There's the red line, our crown prep. And have a look at that. This is our core. Now, looking at our core, you can see the vast majority of it is made of not tooth. It's actually made of a core material. So again, composite, let's say. And if you put a crown on there, just look at how thin this area is. There's very little tooth thickness there. So over time, with function and lateral function, if you've got group function on this tooth, it's not that much of a surprise that that little bit of thin bit of tooth that's left in the core could fracture and then tooth decoronates. Now, this is very common, and it happens a lot on smaller teeth. So premolars, this happens a lot on, and if you've got crown prep on a heavily damaged upper lateral incisor or lower incisors, these are teeth that you often see decoronating if they've got a very damaged tooth with a full coverage crown. Now, let's go back to the same tooth and look at a different scenario. So on this tooth, what if instead of doing a full coverage crown, this is a sort of preparation and restoration that we did on it? So basically, it's just sitting on top of a tooth. We've not gone down all the way down to the gums. And comparing to our full coverage crown preparation, you can see just how much tooth structure we've saved. Now, this is a 2D diagram. The truth of it is that green area is, 360 degrees around the tooth. So that's a lot of tooth volume we've saved, especially down near the gum level called the pericervical dentine. And going back to this again, you can see how much more thickness we have down near the gums. So this tooth is far, far less likely to break at gum level and decoronate. This is what I call an onlay, and we're going to talk a little bit about this and terminologies. But again, yeah, we save a lot of tooth structure, and these teeth don't decoronate. This is a real life example. I took this photo that I found on the internet. And this looks like a pretty decent preparation, nice and smooth. It looks like a small tooth, so probably a upper or lower premolar. But have a look carefully and look at how much of this, the core of this crown prep, is actually not tooth. So the blue outline there, that's a restoration. Let's go back again, and if you have a look. So yeah, look at how little and thin bit of tooth is left on the side there. So I would imagine this tooth would be at a high risk of decoronating. Now I'm talking about onlays. Different people call them by different names. I did a quick, again, Google search on inlays, onlays, and all these different terms that we call them, overlays. And these are some images that I just picked from Google, and I've put them all over here. And it's all a bit confusing. For example, if you have a look on here, what they're calling onlay here is this partial thing on the side. But if you look down here, they're calling an onlay as something that covers the top of a tooth. And this is, again, very confusing. Inlay, onlay, and overlay. So what I found is the terminology is not consistent. And in all truth, different people call it different things. So I'm going to tell you what I call things. And this is just purely because how I was trained. Let's have a look at these terms. Inlay, onlay, inlay, overlay, crown lay, and crown. I'm going to bunch them together. So on the left side of the screen, onlay, overlay, and crown lay, for our purposes tonight, they're all the same thing. So that's what we're going to talk about. Onlays, overlays, and crown lays. I call them onlays. That's how I was trained. If you want to call it an overlay or a crown lay, you can do that. We're going to define that a little bit better. Basically, it's that restoration we're talking about is full cuspal coverage, but it doesn't necessarily come all the way down to the gums. So it's adhesively bonded. We're going to talk about that a bit more. A crown, we know what that is. Full cuspal coverage, traditional preparation all the way down to the gums. And an inlay is, we're going to talk about it as well, is basically when you don't actually cover cusps. This is what I call an onlay. Full cuspal coverage and sitting on top of all of the cusps. These are some of my photos. So that's the sort of thing that I would call an onlay, but you can call it a crown lay or an overlay if you want to. But for tonight, we're going to call them onlays. So this is what I would call an inlay. And I'm going to put a thumbs down next to that because it's not something that is my workflow. I don't do inlays. And why don't I do inlays? They don't cover any cusps. The reason I want to do an onlay or an indirect restoration on top is because I've got a tooth which has thin cusps, which might have cracked cusp syndrome, which might have crack lines. And I want to protect this tooth from fracturing, from breaking. This doesn't achieve any of those. The cusps are not covered. It's just restoration sitting inside the tooth, and the cusps could still break. This tooth could still fracture. So it's not achieving anything useful, in my opinion. In fact, there's some research that shows that these type of indirect restorations call a wedging effect inside a tooth, so they could actually increase the risk of tooth fracture. And quite frankly, if this is the sort of thing that needs doing, why not just do a direct composite? If you're saying that your composite is getting too big and there's a lot of tooth lost, when in that case, you should probably be covering all the cusps and doing a full cuspal coverage restoration. So in my books and in my practice, I don't do inlays, which is what this sort of thing is. Now, this is a little bit controversial, maybe. I don't do these type of restorations either. So I would call this maybe a partial coverage onlay or partial coverage restoration, where some cusps are covered, but some other cusps are not covered. Now, I say controversial because I know that there are teachings out there which talk about measuring cusp thicknesses. And if they're thicker than 2 or 3 millimeters, then maybe we're okay not covering them. So look, my view is not my view only. I'm aware of many, many other skilled clinicians that also share my view. I've seen too many of these restorations through my career where these cusps were deemed to be okay to leave uncovered, but they've come to me, and because they were not covered, now we've got those cusps fractured. So in all honesty, in my books, 99% of the time, if I'm going to do an indirect restoration on the tooth because I don't want cusps to break, I'm just going to go and cover all of the cusps. I don't want in the future to have the risk of the uncovered cusps breaking as well because I didn't cover them. I say 99% because very rarely, and I've done a handful of these myself, I come across a situation such as this. This is a case I borrowed from Dr. Carolina Perez Rodriguez, which is a brilliant prosthodontist in Melbourne. And she posted this lovely case where a full half of the tooth is completely intact. And you see she's written there, two thick, voluminous cusps. And basically, she's just put in a lovely half the tooth as cuspal coverage. I come across these cases so rarely where I find half the tooth is completely intact, and I find that I need to do cuspal coverage in the other half. But you look, if you come across a case such as this, you can do it the same way. I think this is a great case. The vast, like I said, 99% of the time, if I'm doing this sort of thing, I just cover all of the cusps. What is an onlay? So let's look at definition a little bit. So like I said, I call an onlay a full cuspal coverage restoration. It doesn't go all the way down to the gums. If it doesn't go all the way down to the gums, we've got no retention and resistance form. Therefore, the way we get retention is primarily achieved through adhesion. And we're going to talk about that more. And like I said, there's no retention and resistance form. The preparation is driven by the need to remove any compromised tissue. So you're trying to remove caries that's there, old restorations that are there, any cracked or underlying cusps that are have cracks going underneath them, rather than the need to create retention or resistance form. And also we need to just create space for the ceramic on that occlusal surface. So again, if we compare a traditional crown preparation versus an onlay preparation, a traditional crown has these long walls, which are slightly tapered, 6 degrees or to 10 degrees if you can achieve that. And basically, we need these long, fairly parallel walls because in the past, where we didn't have adhesive technology, these walls were needed with conventional cements to create friction so that our crown stayed on. That's what creates that retention and resistance form. However, in modern dentistry, we can do this sort of thing where we don't have retention or resistance form, but because we have such good adhesive technology, we don't need them. It can stay on the top. It still protects the tooth against fracture just as well as the other one, and is far more conservative. So we're actually removing a lot less tooth. We're going to talk about a little bit about this variation of an onlay called a veneer lay or a von lay. Now, basically, if we call this an onlay, a veneer lay is when on the buccal surface of the tooth, the margin has been dropped down all the way down to the gum or very near the gum. Basically, there's a veneer on the front, but the rest of the tooth is an onlay. So when would you do this? As we're going to talk about, one of the potential downsides of onlays is that you might have a somewhat visible transition line on the buccal surface. So sometimes you luck out, and with whether that's your experience or the technician's experience or pure dental gods luck, the transition line on the buccal is completely invisible. But it doesn't always work out that way. And sometimes, no matter how well or the technician tries, that line can be a little bit visible or can become visible over time. Now, that can be a problem if your tooth is visible in your smile. And so this typically happens with upper premolars, so upper 4s and 5s. So if I'm doing an onlay on an upper 4 or 5, upper premolar, in that case, I will do this type of restoration called basically a veneer lay. So that's a combination of a veneer and an onlay, or a von lay. So that's that variation of an onlay. Pros and cons. So we've talked about this a little bit already. Reduced structural compromise. You remove a lot less tooth, and therefore your tooth stays stronger and less likely to decoronate. And as a result of removing a lot less tooth, we get less close to the pulp. There's less heat generated. There's less proximity to the pulp. So I would argue there's a lot less likelihood of causing pulp problems. Favorable failure modes. The failure mode of a lot of full coverage crowns, it can be decoronation, or it can be pretty bad secondary caries deep down near the gums. And we can have some pretty catastrophic failures, as we all know. Onlays, most of the time, if they fail because the onlay fractured or broke. So a lot of the times the tooth is still salvageable, and you can just restore it again. Periodontal health. Because your margins are often quite supragingival, there's less potential for marginal problems or cement or issues with periodontal health. Now, what about the cons? Technique sensitivity during the procedure, particularly during bonding. Onlays are technique sensitive. There's a lot of steps you got to be careful about. There's a lot of steps you need to know what you're doing. Instant adhesive technique. So you got to be doing it under rubber dam, and just like any other kind of adhesive dentistry, the steps for bonding are crucial, because if you don't do them right, basically you don't get a good bond, and that compromises the whole restoration. So like I mentioned, isolation and moisture control are very important. Precision in all steps, we're going to talk about that quite a bit. And maybe not the preparation part, but the bonding part of onlays is definitely longer than a traditional cementing of a crown. It's done under rubber dam, and again, going through all the different steps of bonding, which we're going to go through. Enamel dependence. The best bond, adhesive long-term bond, comes from enamel. Dentin bonding is good and it's improving, but enamel is gold, and enamel is what gives you the best, longest definitive bond. So as I mentioned, there are cases that I may not do onlays, and that's for this reason, where I have very little or no enamel left. Temporization can be tricky because you don't have retention or resistance form. Therefore, if you did a traditional crown temporary, and you just wanted to stick that on with a bit of temporary cement like temp bond, it just won't stay on. So we're going to talk about techniques for that. And finally, we've talked about this transition line on the labial, or well, on the buccal surface. In which case, if you're going to do that on a visible tooth like an upper premolar, you do a veneer lay or a von lay. Not going to go too deep into the literature, but let's just quick summaries. Lots of studies have been done that show high survival rates. You know, this is an 11-year period with an overall failure rate of 0.3% per year. And I've got a few slides. I don't want to bore you with this. You know, this is another 14-year survival. Basically, onlays work. If done properly, they can last a really long time. They have a very high success rate, and they protect teeth. There's no question about it. And the final one, you know, even on endo-treated teeth, endodontically treated teeth, compared to full veneer crowns, they have a very favorable outcome. When to do an onlay and when not to do an onlay. I'm not into dogma. I'm not a dogmatic dentist. So as much as I love Onlay, and our lecture tonight is about Onlays, there are times I don't do them. So we're going to talk about that. So good cases for doing Onlays. This is one such case. So you can see, as we mentioned, there's a really nice solid ring of enamel around the whole tooth. That's one. This is another one. A good solid ring of enamel around the whole tooth. Another one. I think you get the idea. That's another one. So these are my Onlay preps. Typical Onlay preps, really nice thick enamel. Now, there might be occasions where I don't have a full 360 degrees of perfect enamel. And that's especially true when, say, on a mesial or on the distal, you've got quite a bit of damage and your margin drops down and you're pretty much, you know, equigingival or slightly subgingival, in which case probably in that area you don't have any enamel left. That's okay, as long as the majority of your prep you've got good, decent quality enamel. I'm okay doing Onlays on a case where I'm missing a little bit of enamel on, you know, one area, for example. Now, basically, I'm going to show you when not to do an Onlay. So when not to do an Onlay. This is a typical case, old crown. On the x-ray, I could see that there's caries on there. Now, when I cut this and remove it, this is what I've got. Pretty typical underneath old crowns, for example. When you clean that up, basically there's nothing left. There's no enamel there, or any enamel that's left is so little or poor quality. I'm not into periodontics, and I know that there'll be other speakers that talk about doing Onlays on every possible case. I don't do them on these cases. On a case such as this, I do a traditional core buildup, and I do a vertical preparation crown, or a VertiPrep crown. Some of you may have heard of that. I'm not going to go too much into it tonight, but basically it's a very conservative type of crown preparation where you manage to go subgingival, expose more ferrule, and restore teeth that are very, very damaged. And this is the final restoration. This is another one, an old crown removed. And look, when I've got something like this where there's basically very little tooth left, I don't try to do an Onlay on this. There's no enamel left. Instead, I do a traditional core build-up and I go to my vertical preparation crown. So my practice is divided into Onlays. When I do indirect restoration, Onlays probably around 70% of the time, and vertical preparation crowns about 30% of the time. And that's just an estimate. So that's a nice vertical preparation crown, and you cement that on conventionally. A little bit about material selection. By far, the most commonly used material for Onlays is lithium disilicate. And probably the most commonly used material out of that category is Emax, made by Ivoclar. Emax, great material, lots of years of study and use behind it, so highly trusted, and that's what I use more than any other material. Another example is Lisi, made by GC, and that's another material that's very highly regarded. And I'm using a little bit more of that, but I'm probably still using more Emax compared to Lisi. Gold, wonderful material. I've used lots of gold in the past, a little bit less now because of how successful lithium disilicate is and patient wishes. But to be honest, gold is fantastic, especially posteriorly in the back of the mouth on second molars. Gold is fantastic. Hybrid materials, which are basically when you have a sort of a resin matrix with ceramic material, some sort of a filler inside, they're sort of really good quality composites, think of it. And, these can be used in some low pressure cases, low demand cases. But most of the time, if I'm going to do this sort of thing, I go with lithium disilicate. Zirconia is an interesting one. Zirconia can be bonded. There's no question about that. Go look up the APC technique. If you don't trust zirconia bonding, it can be bonded. To be honest, I've had such success with lithium disilicate and Emax and Lisi. I haven't felt the need to change to doing zirconia bonding and zirconia onlays much, but can they be done? Yes. In terms of preparation dimensions, I'm just very quickly going to talk about Emax, and this is directly from Ivoclar. So I'm just going to circle some things on there. Basically, Ivoclar's advice is if you're going to do adhesive bonding of Emax, then your occlusal reduction could be at least 1 millimeter. If you're going to do conventional cementing of Emax, your occlusal reduction should be 1.5 millimeters. Now, my opinion is, and this is not just me, many people say, most people say, if you're going to do Emax, do not cement it conventionally, you bond it. You only really get the advantages of Emax and the full strength of it only if it's bonded. Cemented Emax is much weaker and much more likely to fracture. So don't do this. No conventional cementation. You always bond Emax. Now, even though in theory, Ivoclar tells me that I can get away with 1 millimeter occlusal reduction, the truth of it is myself and most of the people I know, we still do more. So I will do a minimum of 1.2 up to 1.5, makes me feel much more comfortable when I'm doing occlusal reduction. Okay, I'm going to have a little drink before we carry on into how to actually do onlays. So the complete how-to for onlays. We're going to break this up into 3 parts: preparation, temporization, and bonding. And we're going to talk about each part in turn. Let's talk about preparation first. For the purposes of talking through these steps, I've actually picked 3 of my cases to talk about. That's case number 1, that's case number 2, and that's case number 3. And I'm kind of going to be concurrently talking about all 3 cases because each of these cases has some aspects of what I want to talk about. And in case you're wondering why this tooth needed an onlay, it's got typical crack cusp syndrome. So sharp pain on, pressure on hard things. And there's a very clear, deep crack that runs underneath that mesio-buccal cusp. And there's a crack that goes on the palatal surface as well. All right. These highlighted areas are the parts of the tooth that are basically restorations, and you can see the crack lines as well. So very, very compromised tooth. So I want to cover it so to prevent the tooth from breaking, basically. One of the first things we do is occlusal reduction. And you can see some depth cuts here. Depth cuts are a really good way to achieve predictable occlusal reduction. So I'm going to show you how I do this. And this is the burr that I've been using for many years. This is called an occlusal reduction burr. This particular one is made by Mysinja, but there are other manufacturers now. And basically they come in a kit where you have different types of these burrs. And this part of the burr is covered by diamond. And basically what happens is you just put this on the occlusal surface, and when you run it through mesiodistally first, it cuts in only to that depth. So there are burrs in a kit. There's a burr that cuts to 1 millimeter, another one that goes to 1.2 millimeters, another one that goes to 1.5 millimeters, and so on. And this green one is by far the most common one that I use. I think this is 1.2. So all you do is you put it down occlusally, you run it mesiodistal, and then you come back to the middle, you run it towards the buccal, towards the palatal, and then you do other buccal palatal and other buccal palatal cuts. So the great thing about this is predictable. I now know all these depths are 1.2 millimeters deep and not more. And all I got to do then is to pick up another diamond burr and join these grooves together. And that means I get a predictable 1.2, with a little bit more reduction, 1.5 millimeter of occlusal reduction. So afterwards, once you've joined the grooves together, that's the sort of thing you see. So that's the occlusal reduction done quite predictably. And this is the sort of burr I would use to join them together. Just a coarse diamond burr with a bit of thickness on it. Okay, I'm not going to talk too much about very particular types of burr to use tonight. I don't think you need to buy a certain kit for onlay preparations. I don't believe in that. It's more like using the burrs you already have, as long as you know what sort of thing works. And I'm giving you an example here. Once you've done your occlusal reduction, basically you then take out all old restorations. I'm a big believer in removing everything old in the tooth. If there's old amalgam in there, you take it out. If there's old composite in there, you take it out. The only exception to that is if the old composite was done by myself or by a very trusted colleague, so I know 100% that is a good quality composite. It's bonded well. There's no secondary caries under there. But my advice to you is, if a patient walks into your room and you're going to do this on them and there's some kind of an old restoration in there by somebody else, take it all out, start from scratch. You don't want to be doing this over somebody else's restoration because you could be missing something. So take everything out, and that's called dismantling. So we've done occlusal reduction and we dismantle. Switching to another case. So again, occlusal depth cuts, and the old amalgam has been taken out, and I joined the depth, and this is what it looks like from the side. You can see those depth cuts, and then join them all together, and that's my occlusal reduction and dismantling done. At this point, if there's any caries, you've got to remove your caries. You can see from here to here, the tooth looks a lot more matte. What have I done? I've sandblasted a tooth. I'm a big fan of sandblasting. So I often sandblast teeth quite early on because it increases visibility. I can see what's going on. I can see cracks really well in the tooth. So as we're going to talk a little bit about this, I think sandblasting is actually rather mandatory for doing this kind of treatment. So I hope you guys have a sandblaster. If not, get one. Ask one to be bought for you, or get one for yourself. So this is where we started off. I've sandblasted. Now I want to check to see if there's caries in there, and I'm a big fan of using caries detector dye. Again, one of those things that I think every dentist should be using in modern dentistry. It is so easy to miss caries where you can't see it if you don't use caries detector dye. Likewise, it is so easy, if I go back to the previous slide, to have a look at the tooth like this and look at all that brown area there and think, oh, maybe that's caries, maybe I should remove it. So you remove too much. Now let's see what happens after I put caries detector dye and then I wash it off. And after I wash it off, there's actually very little pink there. You know, there's little bits that go into the crack lines, but nothing else there. So this area here is certainly not carious. It's just some staining from amalgam byproducts that have been absorbed into the dentine. So if you pick up a drill and start drilling over there, you're removing it unnecessarily and potentially, you know, getting closer and closer to the pulp of the tooth with potential pulp problems. So caries detector dye for not missing caries, but at the same time, not removing unnecessary caries. So occlusal reduction done, dismantling done, caries removal done. The next step, we got to do IDS, immediate dentine sealing. We're going to talk, we've got several slides coming up on this a bit later on, but basically I've done etch, prime and bond, and I've bonded my whole tooth surface, well, the dentine, and I've put a thin layer of flowable composite over the dentine. All right, this is very important. I've got several slides coming up on this a bit later on. Switching to another case now. So looking at the tooth from the side, so far, let's say, again, summarizing, we've done occlusal reduction, dismantling, caries removal, and I've done my immediate dentine sealing. Now we've got to do our margin preparation. I do what I call rough margin preparation first. So I use a coarse burr, not a fine burr. I use a coarse burr, and I start to do my margins on the buccal, on the lingual, and interproximally. Okay. Then, as I'll explain to you, I convert that to a smooth prep. So first I do a rough prep, then I change that to a smooth prep. For interproximals, I'm a huge fan of using these things called wedge guards made by Triodent, or there's another brand often called fender wedges. I like to insert these between teeth routinely when I do any kind of interproximal preparation. I don't want to accidentally touch a tooth next door. So I advise you, if you have these, use them. It is so easy, even for the most experienced clinician, to just touch and scratch your tooth surface next door to where you're working. So basically you insert it between the teeth, and it makes it far safer to do interproximal work. For interproximal areas, again, I've just initially start off with a rough diamond, but it's nice to have a narrower one. So have one which is thinner, so that you can start to go interproximally. I'm going to talk more about margin design. That's several slides later. So bear with me, because I'm going to talk about what kind of margin design to be doing. But for now, what you need to do is you do your margin prep on the buccal, lingual, mesial, and distal. This is what I now call as my rough preparation complete. So I've done my buccal, my lingual, my mesial, and my distal margin preparation. It's rough, but it's pretty much where I need it to be. I now convert this to a smooth prep. Summary so far. We start off with occlusal reduction, dismantle, and caries removal. And then we do immediate dentine sealing and rough margin preparation. All right, we're going to take a quick breather. Let's talk about immediate dentine sealing. Application of dentine bonding agent to freshly cut exposed dentine immediately after tooth preparation, prior to taking an impression or placing a provisional restoration. So it's done on freshly cut dentine. This is very important. It's called immediate dentine sealing. It's not delayed dentine sealing when you do this to dentine that was cut a week ago. You put this immediately on fresh cut dentine, because that dentine at this stage is uncontaminated. No bacterial contaminants have gone down into these freshly cut dentinal tubules. So it's been proven again and again through many studies that you get the best bond strength to dentine if you do bonding to it immediately after cutting and you don't delay it. So if you've put temporary cement on the dentine, and then you're doing bonding like a week later, that temporary cement contaminates the dentine, and your bond strength is lower. Also, your bond strength has been shown to be maintained to dentine long term, rather than doing delayed dentine sealing, where the bond strength may start off okay, but over the years, your dentine bond drops down. So you apply dentine bonding agent immediately to freshly cut dentine, and then you do finish off your preparation, and you take your impressions or scans and you put your provisional restoration on. Maximize bond strength, as I mentioned. Elimination of postoperative sensitivity, because your dentine is bonded, all your tubules are blocked and sealed. During that temporization period, where the patient's got a temporary on a tooth, they're not going to have any sensitivity. Prevention of bacterial micro leakage into the dentinal tubules. So again, the risk to pulpal health is far diminished. And improve restoration adaptation. When you've done your occlusal preparation and caries removal and dismantling, often your prep might be pretty uneven and rough on the occlusal surface. They have lots of ups and downs. So when you do immediate dentine sealing and you put your bond and some flowable composite on there, it's actually a really nice time to even all of that out and get a really nice flowing surface, which means your prep is nice and smooth and flowing, and that means your restoration is going to have a much nicer intimate contact with your tooth. These are the basic steps of immediate dentine sealing. So first, we've done the bulk of our tooth preparation. We sandblast, big part of adhesive dentistry, because sandblasting is what gives you the cleanest, most conducive surface for bonding. And then we apply our adhesive. Adhesive, you can use what you have in your practice. The gold standards are Generation 4, which is separate edge, separate prime, separate bond, such as OptiBond FL, or Generation 6, which is a 2-bottle system. So those are the gold standards. Whatever you do, make sure you follow the steps exactly. So go read your instructions for use for your bonding system and just follow them to the letter. If it says, edge for 20 seconds, you edge for 20 seconds. You rinse that off. If it says apply primer for 20 seconds and air dry it, you do it for 20 seconds, not any less, and so on. So don't skip any stages. This is super important. Just make sure you do it very much by the book. Resin coating. Once you put your adhesive bond on there, you want to apply a thin layer of flowable composite over the top of that. So this has got 2 functions. The first one is that it actually protects your bond. Once you put adhesive onto your dentine, you create what's called a hybrid layer, where the resin tags are going inside the dentinal tubules. And that hybrid layer is pretty fragile, and it's easy to pull those resin tags out of the dentinal tubules. If you've got polymerization shrinkage later on, by adding a thin layer of flowable composite on top of that bond, you're actually giving it a bit of strength and protecting that hybrid layer so the resin tags don't get pulled out of the dentine. The second function is, well, as I mentioned before, by having some flowable composite added on top, now's the opportunity to get a nice flowing surface and getting rid of uneven occlusal surface after your prep. The only time you don't need to do resin coating is if you've used OptiBond FL, because OptiBond FL is a highly filled bond. It's about 40% filled, so it already gives you a very thick, strong layer. But if you're not using OptiBond FL, everything else, you should be using a thin layer of flowable composite, about 0.5 to 1 millimeter. The final thing is you got to remove the oxygen inhibited layer, which is a very thin layer of resin on the surface, which doesn't fully cure because the oxygen in the air chemically inhibits it from setting. So once you've done your resin coating, you've got to put an oxygen block on top, such as glycerine. This stops the oxygen from touching the surface, and then you're going to cure that again. And that fully cures the resin that you've put on top. So these are the main steps of immediate dentine sealing. Let's talk about margin design now. I'm putting 3 types of margin design here. On the left side, we've got flat. In the middle, we've got a bevel, which is kind of like flat, except on the sides, they've been beveled a bit. And on the right side, we've got a little shoulder. So basically, a little shoulder's been dropped down. It's not like a full crown prep. You don't go all the way down to the gums, but it's definitely more than a bevel. The flat on the left side, some people use that. I don't. My advice to you is don't use a flat prep for 2 main reasons. If you use a flat prep on the edges, you're going to have some unsupported enamel prisms. And those enamel prisms, because of the way they've been cut, you've got to look at the enamel prism anatomy. They are more likely to chip and break off long term, so you kind of end up with a ditched margin. By beveling, the way it's beveled, you're not going to have basically unsupported enamel prisms. The second reason for beveling is that you get much more surface area of enamel for bonding. So bevel and shoulder are both valid margin designs. And we're going to talk about pros and cons of each margin design and when to do them. Let's look at a bevel first. A bevel is definitely more conservative. You remove less enamel, so you're preserving more enamel. However, you leave a more flat preparation. And that can be a problem because if you have a very flat preparation all over your onlay prep, when you've made your onlay, on the day you're about to bond it, this onlay doesn't stay put. It kind of glides over the surface. It's very hard to locate it exactly where it's supposed to sit. You know, when you've got a crown and you come to cement it, that crown can go on only one way and no other way, so that you can't get it wrong. But with a flat onlay, it can hover about. So when you come to bond it, it's actually super easy to get it wrong and bond it a little bit buckle or a little bit palatal where it's supposed to be. And that's not a good thing. So it can be difficult to locate the onlay during bonding. Unless there are other features that stop it from gliding. So if you've got boxes on the mesial or distal or some other feature, those boxes can stop it gliding buccal or lingually. So it might be okay to do bevels on buccal and lingual because it still doesn't move. But if you don't have boxes and the whole thing's very flat, then you might be in trouble. So let's look at a shoulder. Removes more enamel, but not much, just a little bit. However, it definitely has more definite seating and locating. So on the bonding day, this is far easier to locate. It goes exactly in one place and it doesn't hover about. Okay. Now, when I look at my tooth, I choose bevel or shoulder depending on what's going on with the tooth. If I can, I go for a bevel because it preserves more enamel. However, if I find that it's all looking very flat and, you know, I might then do a shoulder. Conversely, sometimes I might find that in one area, may say on the lingual side of a tooth, there's already quite a bit of a defect. There's quite a bit of tooth gone. So if I do a shoulder on that side, I might lose that little bit of enamel that I've got left. So I don't want to do a shoulder there. I want to preserve as much enamel as I can. Therefore, I'll do a bevel on that side. So you've got to pick and choose your margin design depending on your tooth and the situation and how much tooth is left and how much enamel is left. You can absolutely combine the two, and I do this quite regularly. So this is an example where I might do a shoulder on the buccal and a bevel on the lingual, and you just blend it into each other. So there's no reason why you can't do one in one area and one in the other area. Now, same margin designs apply to buccal, lingual, but also mesially and distally. So mesially, distally, you can also have a bevel or a shoulder, and the same principles apply. The only thing I would say about interproximal margin design is make sure your margins, you drop them below the contact point. So I'm not a fan of leaving a margin at the contact point or really above the contact point. I'm going to mention why. Definitely not at the contact point. 99.9% of the time, it's just below the contact point. It's much easier to prep, much easier to impress, much easier to scan, much easier to temporize, much easier to bond, much easier for everything. And it's not that much more tooth preparation to go below the contact point. Why not above the contact point? Because in 99% of the cases, if you stay above the contact point, that marginal ridge becomes very, very thin. And I'll be very worried about that breaking long term because there's not going to be much ceramic thickness there. So interproximally, almost always go just below the contact point. Let's talk about a bevel and a little divot. So you know how I said if you've got bevels everywhere, and then your prep becomes quite flat. It can hover about. So let's say we've got a prep like this, and now my prep looks like this. It's pretty flat everywhere. It's going to hover about. If I've done my resin coating and I've got, a good bit of composite in the middle, or like sort of a composite core in the middle, then I could put a divot in the middle. And this is just like a round divot in the middle. This is a locating feature. It means I don't have the problem of this hovering about anymore. My onlay on the intaglio surface is going to have this protruding bit which sits into this divot. So during my bonding, it stays put. So this is a nice trick to do, but only do a divot if you've got composite in the middle of the tooth. Don't cut a divot into dentine. I don't like doing that. I like doing it only if I've got composite. Then I'm happy to cut a divot into there. And this is what a divot looks like. There's composite there, and there's just a round depression that I've made using a fairly large round burr. Okay, we can carry on. So far, we've finished our rough preparation. And this is just done normally for me using coarse burrs with my fast sand piece. And it actually doesn't take that long to get to this stage. You don't spend masses of time on a rough preparation. However, you're now going to convert this to a smooth preparation. And look at the difference from there, everything looking rough, to this. And this is what we want. We want our prep to be refined. And we call this refining the prep. And in fact, this step from my rough preparation to the refined preparation, that's probably what I spend the most time on. In time-wise, that's what I spend the most time on. How do we do this? Look at examples. This is rough prep. This is after refining and smoothing. This is another case, rough prep. This is after smoothing. At the top, rough prep with IDS. At the bottom, very smooth, crisp, sharp margins, nothing rough. Smooth preps matter. There's a lot of studies on this, a lot of evidence on this. You get better impressions, better scans. If you've got rough prep, what is roughness? Roughness, if you zoom in, is basically bits of enamel, bits of dentine that go up and down. Now, impression materials or your scanner may not be able to record these tiny bits in your preparation. And if they don't record it, then certainly when you're milling it, or the technician is pouring these into stone, if it's in stone, those rough bits probably fracture. So then you make an onlay on there, which has got a poor marginal fit. If you're doing this using milling and CAD/CAM technology, your scanner never picks up these rough areas, these uneven bits, and the drill of the milling machine certainly cannot mill these very fine bits. So you basically end up with worse fitting restorations. So smooth preps gives you better impressions, better scans, and therefore better fitting restorations. Another thing is over-milled restorations. If you've got sharp margins inside your preps that are rough, the drills of the milling machine, they have a definite thickness at the tips. So if you've got a very sharp corner in the middle, that tip cannot mill that out. It physically can't do it. So the only way the machine can compensate is to over-mill it and thin out that area of the onlay too much for it to be able to sit onto your preparation. And guess what? That just means your onlay just became unnecessarily thin and weaker in that spot. You get better bond strengths. There has been this sort of belief or urban legend that if you have your preps rougher, you get better bond strengths. That's absolutely not true and disproven in lots of studies. For all the reasons I've mentioned here, if you have smooth preps, that means you have better fitting restorations. That means you get a much more even cement and therefore much better bond strengths. So take time to make your prep smooth. It matters. How do you make a prep smooth? If you have one of these handpieces, this is very, very useful. This is a speed increasing electric handpiece, or AKA a red band handpiece. These are electric handpieces, which means they go on the same handpiece that your slow handpiece goes on. However, they take fast handpiece burrs. They get friction grip burrs. So why is this important? With these handpieces, you can run them at a constant low speed, and low speed is what you want for smoothing and refining preps. Think about it. With your fast handpiece that runs by air, your regular fast handpieces, how easy is it to run it at a constant low speed? It's not. It keeps increasing and decreasing in speed, doesn't it? And every time you try to touch your tooth to smooth it with a fast handpiece at low speed, the burst stops. That doesn't happen with these handpieces. It can run at a constant low speed, constant torque, and that constant low speed is very, very useful for being able to refine and get smooth preps. Now, this is what I do. I've done my rough prep. I've got my speed increasing red band handpiece electric motor. I use a red band burr, so a fine burr. I come to my tooth and I run this dry without any water. And I'm going to explain why. My DA comes with a triplex and blows constant air on the tip of the burr as I carefully smooth my prep. So no water, because water obscures your view. Without water, it's far, far easier to see your prep smoothness and what you've achieved. If you haven't tried it, give it a try and you'll see what I mean. You're blowing air onto there to cool the tooth down, but also to get rid of dust that's settling onto the tooth. Sometimes people say, but isn't this going to heat up the tooth too much? It's not. You've done the vast majority of your tooth cutting already. You're doing very little cutting here, and it's gentle touch, low speed, so there's barely any heat generated, and you're blowing air onto it anyway. So if you've never tried it, try it. Do this dry, low speed with your DA blowing air on it. And you do this on your buccal, lingual, mesial distal margins. And then onto the occlusal surfaces as well. You want to have flowing surfaces, nothing sharp, nothing rough, no sharp internal angles. A selection of burrs that I use. This is not definite. You know, each of you can have a look, but I'm just going to give some suggestions. Some sort of thicker burr on the left side with round tips. I normally have two, one which is a bit thicker, one which is a bit thinner. The thicker one I use on the buccals and linguals. The slightly thinner one I use interproximally. Sharp burrs are useful, such as this is more like a flame-shaped one, or if you have a needle-shaped ones. These can be very useful interproximally. It can be very useful in the four corners where the buccal and the interproximals are joining together. Some sort of a rugby-shaped burr. These are very useful for the occlusal surfaces or for rounding the internal line angles. Once you've done as much smoothing as you think you're going to get away with using your red band handpiece, then polish your surface with your choice of polishing rubber cup or point or whatever you have. So literally in your slow handpiece, water on, smooth your prep occlusally. Very useful. Interproximal areas to get very smooth edges. So you can see this one is a bit rough and jagged. There are some useful things you can do to go from there to there. You know, when there's a neighboring tooth next to it. Polishing strips, plastic or metal diamond polishing strips. You can wrap it around the tooth interproximally and just gently move it back and forth. Very useful. Sometimes a sharp, thin sickle scaler can be very useful to smooth those edges. And like I already mentioned, a sharper tip burr, like a flame-shaped or a thin needle-shaped burr, running slow speed interproximally. So I've done my prep. I'm happy. I now need to take impressions. I take my rubber dam off. You got to look at your margins. You got to look at the gum, and you got to make sure that if you take an impression, or particularly if you take a scan, all your margins are going to be captured. You can see here that gum is bleeding, it's equigingival. You can put a retraction cord there. You can use PTFE tape there if it's just a little bit there. Sometimes what I do, because it works and it's very easy, I just use a little bit of electrosurgery. You can use laser if you want to. It's very quick, very safe. It's minor, and that gum, it just cauterizes beautifully like this. And afterwards, all that gum grows back and it stays dry. It doesn't bleed. So very useful if you've got quite a bit of inflamed gum there because of a poor previous restoration. And this just makes it perfect for taking impressions or scans. If it's fairly minor, you might be able to do this with a retraction cord. Now I take my impression and my scan. So preparation done, scanning and impression done. We're going to do temporization. And temporization is something that catches people out with Onlays, because you can't do your traditional bisacral or acrylic temporary crown and just stick it on with a temporary crown. It's just going to, with a temporary cement, it's just going to fall off because it's got no retention or resistance form. So we're going to talk about 3 different techniques and my favorite technique. So the first one is still making a bisacral onlay. So the same temporary material like ProTemp or Loxatemp. You do the same thing inside a putty that you've made. You stick this on, not with temp bond, but with zinc polycarboxylate, such as Duralon or Poly-F. It sticks a lot better and a lot stronger, so it's far less likely to come off. So this is your ProTemp or Loxatemp, which has been stuck on, but even this isn't quite enough. So what you've got to do, you've got to spot etch on the buccal and lingual margins and just put a little bit of dots of flowable composite on the buccal and on the lingual. And this is normally enough to keep this in place over the next couple of weeks. Super important. You always tell your patient, do not eat on this. Soft diet, put the fear of God into them. If it comes off, how much of a hassle it is to them to have to come back to you to put it back on. So if you scare your patients enough as well, it often stays okay. It's a good thing. Scare your patients. There are also these products called, which are temporary light cured composites called Clip or Telio Onlay. I've used these in the past. When you put, basically you get a big blob, you put it onto the whole occlusal surface and then you light cure it. It never goes super hard. It always stays a little bit sort of flexible, because next time when they come in, you kind of just peel them off. In my hands, they were reasonably predictable, but sometimes it just came off. So I was never a huge fan of these, but if you want to try them, you can try them. They're very quick to do. And this is something that has been my go-to technique, which is using the zinc polycarboxylate cement just on its own. So zinc polycarboxylate, a lot of people haven't used it. Common brand is Duralon, Poly-F, and basically it's a liquid and powder. Now I'm going to tell you how I do this. Some people find this unusual, but it's worked very reliably in my hands. You've got to have a glass slab. This stuff is very, very sticky, quite tricky to mix. Powder and liquid go onto the glass slab, and you mix it with a plastic spatula, and it becomes a nice thick paste. And you basically pick this up on a flat plastic and you apply it directly to your dried prep. Once you've put it on, it's all very, very sticky. You've got to Vaseline your fingers, and you go with Vaseline fingers to shape this, and you dab it down. Now, when you dab this down and you shape it, you go everywhere. You go over the buccal margin, you go over the lingual margin, and you go interproximally into the embrasures. So it's a bit messy, and I don't try to adapt it to the margins. I go over the margins, and I then go into the embrasures. And This sounds shocking to some people. I then just get the patient to bite into it. Once it's a little bit drier, it takes about 5 minutes to dry off and set. And then I check the bite, and then I give the same instructions about being careful. And then it stays on really well. When the patient comes back about a week or two later, you then, normally what you got to do is you got to grab a sickle scaler and you just stick it underneath and pull hard, and it comes off. If it doesn't come off, normally some thinning with a burr or ultrasonic breaks it off, and it all comes off nicely. Now, I said I stick this into the embrasure, and the patient can't floss, can't use pixies really. So, however, afterwards, the gums always look good, which is quite interesting. Zinc polycarboxylate has got antibacterial properties, and it's very biocompatible. The gums like it. And in that 1 or 2 weeks, even though it's gone over the margins and into proximally, this is literally what it looks like once you take it off. The gums just never really look that bad at all. They look pretty healthy. So that's been my experience with it, and it works really well in my hands. It's been quick to do, it's been reliable, easy to get off, and easy to clean off. And once you get it off, basically, you then put rubber dam on and you carry on with your bonding. All right, preparation, temporization done. Now we're going to talk about bonding. Rubber dam goes on. You have to sandblast. Very, very important. Pretty much mandatory for Onlays. Your IDS surface, that set bond and flowable composite that you put on there, you need to reactivate it to be able to bond onto it. And that needs sandblasting. You try in your onlay that you've received back, so it's a dry fit, to check your marginal fit and make sure you're happy with it. And these are my steps. I like to stick my onlays onto a microbrush using some blockout resin, which is basically some blue flowable composite. If you don't have it, just use regular flowable composite and it just sticks onto this. I've got a little handle to pick it up so I don't have to hold it between my fingers. It's too hard and too fiddly. Then these are the processes that we go through. You need to etch the ceramic, and for Emax or lithium disilicate, use hydrofluoric acid 5% for 20 seconds. This is what Ivoclar tells you to do. And then you have to rinse that off. And then you get some salt precipitates that come on the surface. You've got to get rid of those. You wash it off. You apply, there are 2 ways of getting rid of the salt precipitates, and that's one by applying phosphoric acid for 30 seconds and washing that off really well, or the gold standard is supposed to be ultrasonic bath in distilled water or alcohol for 3 to 5 minutes. If you have that, that's fantastic, use it. I've personally been using phosphoric acid for 15 years, and I've never had a problem with it. But if you want to use ultrasonic bath, you're welcome to use that. You dry it really, really well, and then you apply your silane coupling agent, and you leave that to air dry. Just leave it on the side for about 60 seconds. I took these pictures, which are quite fun. You can see the silane coupling agent. You see the wet area. If your surface is really nice and reactive, once you put it on, it just spreads on its own, and it kind of gets absorbed and reacts with that etched ceramic surface. So your onlay is now ready. You've put it on the side. You come to your tooth. You've got to now do the bonding procedure on your tooth. Etch and whatever bonding system that you have. Cement choice. What do you use? We have dual cure resin cements. We have light cure resin cements. And we have self-adhesive resin cements. Some typical brands here. We're not going to go through brand choices. What you need to know is, do not use self-adhesive resin cements. They're not appropriate for adhesive bonding of lithium disilicate or onlays, that you just don't get a good enough bond, okay? So sometimes I ask people, what kind of cement you're using? They say, I'm using Reliex. Then I ask them, which one? Is it Reliex Unisem? Is it Reliex Veneer? Or is it Reliex Ultimate? They are different things. So whatever cement you have, go make sure that you're using either a dual cure resin cement or a light cure resin cement. Dual cure is probably the most typical one that you use, particularly if your onlay is very thick, because in the thick areas, you might be worried that the light might not be reaching all the way to the bottom. So if you use the light cure resin on its own, you might be worried that you can't get the light cure to the bottom, in which case use dual cure. But if your onlay is not super thick, a light cure resin cement's good as well. I'm not going to talk about it too much, but you could also use heated paste composite. You got to have a composite heater. You can't do it. You can't do this with any type of paste or packable composite. It's got to be some particular ones, because only some particular ones have been shown through studies that if you heat them and you use them underneath onlays or veneers, you get it thin enough. A lot of other composites are not suitable because you don't get a thin enough film thickness. My bonding has been done here. By the way, the one that I use myself is GSEM Linkforce. That's what I have in my practice, and GSEM veneer, which works very well for me. Sometimes I use heated paste composite with Filtech Z250, but most of the time, GSEM. Bonding has been done, and then you have your onlay, you load it up with your cement, and you put it on. Now, when you put it on, this is what it looks like. We're going to talk about how to do cleanup quickly. This is a step that a lot of people get nervous about, and they get it wrong, and it causes problems. So I'm going to tell you sort of a foolproof way that I do it, and it works really well in my hands. The first thing you might notice here is I have not wrapped my teeth around in Teflon or PTFE tape. Maybe a little bit controversial. I know a lot of people advocate doing that. I've done it sometimes, but vast majority of the time in my career, I haven't done it. And it works fine as long as you follow the steps like this. It's far quicker, less fiddly, and I've never had a problem doing it this way. So let's say you've put your onlay on, you've got all this excess cement that comes out. Now we've got to clean that up. I pick up a ball burnisher myself, and I put it onto the top of a tooth, and I hold it firm in place. And then I pick up bristle brush applicator or a paintbrush, and then I wipe all this excess off really nicely. And then I hold it out and get my DA to wipe it. And then I go back and I clean off more from the buckle, from the interproximals, and I get my DA to wipe it every time with gauze. Bristles are much better than a micro brush. It's much easier to clean off the cement. So go around really well, get off as much excess as you can. Then my DA holds the tooth in place using the ball burnisher. So this is now my DA holding it, and I floss through carefully. I push the floss down into proximally, and I pull it out. I might do the same side twice. Then my DA lifts off the ball burnisher. I go to the other side. DA puts the ball burnisher back on, and I floss through again on the other side maybe a couple of times. So I'm getting rid of that excess cement interproximally. So the vast majority of the cement's now been cleaned off, and it looks something like this. Now I put my own finger down onto the onlay, and I push down really hard, and I mean hard. My finger hurts because of how hard I'm pushing. And I bring my light cure and I give it a good zap from the buckle and from the lingual. And that secures my onlay into place. So it's not going to come off anymore because I've cured it from the buckle and the lingual. At this stage, I've got a nice thin sharp sickle scaler. I go mesiodistally and do a really good clean mesiodistally. And if I've got it as well, sometimes I use a number 12 blade. This stuff's amazing. If you don't have it, get yourself some. And I go with an ultrasonic scaler as well, mesiodistally. Okay, so sickle scaler first, then ultrasonic. Then I apply some air barrier gel like glycerine onto the buckle and lingual, and I cure really well. So I do a full cure now, through this, and this is again to get rid of any oxygen inhibited layer. It allows that margin to, any little bit of composite in the margins to cure very well, less staining in the future, less marginal breakdown. And now I do a check with floss interproximally to make sure it's all very, very smooth. If I still find there's a catch in there, I go back in with a sickle scaler or ultrasonic. And now it's polishing time onto my buccal and lingual margins, and use your own polishing points or cups that you have, water on and polish really well, buccally and lingually, or any surface that you've got access to. You can also put polishing strips between the teeth, plastic polishing strips, to polish interproximally. And that's it. You then take your rubber dam off. You do an occlusal check. If you need to do any adjustments, you do that. Any areas that you've adjusted, you repolish using special ceramic polishing burrs. Always, always take post-operative radiographs, because without them, you could easily miss excess cement left interproximally, which you will just miss, and it will cause chronic gingivitis and problems. And if you pick up any excess cement left at this point, then you can clean it off. Hopefully you're not going to find an open margin, because if you've got an open margin, it's probably a redo. But always take a post-operative radiograph. Okay, the 3 cases that we had, these are befores and afters, before and after. And this case I literally did 2 days ago on Monday. That's the before and that's an after. For several years now, we've had CEREC in our practice. So I've been making my own onlays myself. So this is an Emax onlay, which I've stained and glazed myself. All right. Post-op instructions. There's only a little bit left now. I always tell my patients that there's going to be gum soreness. My advice to you is tell them you're going to have sore gums. Don't be surprised. If you need to take a bit of Panadol, take it. But make sure you brush and floss normally. Do not avoid the area. No matter how carefully I've checked the occlusion, I tell them that there's a small chance later on today you might find that the bite is a bit high. If it is, give it 1 or 2 weeks. Most of the time, it goes away on its own. If it didn't go away, and if it was annoying you, come back and see me, and I'll adjust it for you in a couple of minutes. These two, if you tell them, they will dramatically reduce the number of post-op phone calls that you get later on, patients telling me my gum is sore and my bite is a bit high. So big tips. Always warn about pain from gums and the possibility of a slightly high occlusion. Sometimes I warn my patients about the risk of nerve problems. If I've ever gotten really close to the nerve of a tooth and I'm a bit nervous, I tell them, we got close to the nerve of a tooth, there was deep caries, there was deep cracks, close to the nerve of a tooth, there's some risk that you might have future nerve problems. If so, you might need a root canal treatment. It's a good time to say this now, because it sounds like a diagnosis rather than later when it's happened, when it sounds like an excuse. Risk of fracture, not really. Only if someone's a heavy bruxer and I've happened to do an Emax on a second molar. On those teeth, sometimes gold is the best option. So if I'm worried that this person has insisted on an Emax on a second molar and they're a bruxer, I warn them that, look, if this happens and the Emax breaks, then we might have to do gold for you. The bonding, I've now summarized it on 3 slots, so you're welcome to take pictures of these 3 slots because they can be good kind of cheat sheets. Always numb up, remove temporary sandblast, put the rubber dam on. Onlay, dry fit. You prepare your onlay by sticking to the microbrush, putting hydrofluoric acid on it, removing the salts by using phosphoric acid or ultrasonic bath, salinating. Then you prepare the tooth. You'll do your bonding procedure. You load the cement and you seat the onlay. Then you got to remove the gross cement, buccal and lingual. You put a burnisher on the tooth. You use a bristle brush to remove the cement. You use the gross cement interproximally. Your DA holds the burnisher on the tooth and you carefully floss through interproximally yourself. Finger on tooth firmly. You light cure from the buccal and lingual. Remove the excess cement interproximally using sickle scaler and ultrasonic. Number 12 and ultrasonic. You always use floss to check, make sure it's all smooth gliding, and then you polish your margins. Finally, you remove your rubber dam, you check your occlusion, adjust if needed, repolish, you take your post-operative radiograph, and you give your post-operative instructions. And I think that might be it. So there was a lot to cover. There was a bit of a whirlwind journey through Onlays. Like I said, I've been doing them for a very long time. I've now been qualified 20 years. I've been doing them for about 18 years of those, and a highly, highly successful treatment modality in practice. Thank you very much.
Thank you, Dr. Bez, for a very informative webinar.
Ran quite long, I know.
Long, but it was well worth it. I would agree, and I'm sure many others have agreed as well. So thank you again. So we'll go through some of the questions here in the chat. So if you haven't posted a question, please pop them in now. Now's the time. So we'll go through these here. The first question from Dr. Hira. She has a scenario. It's a 1-4
forecast. Top of that abrasion survival in this case. It's, in all honesty, it's very hard to tell unless you actually see a photo and an x-ray of a tooth. It could be that this tooth is perfectly suitable for doing an onlay or a veneer lay on it. There's a mention of an abrasion cervically. If there's an abrasion cervically, sometimes I might do a class 5 composite. I'm very happy to combine onlays with class 5 composites. Or if you're going to do a von lay or a veneer lay, then you might design it so that the ceramic extends up to, you know, as a veneer and cover up that abrasion cervically anyway. Sometimes, a lot of the times, these premolars, if they're highly, highly damaged, I kind of have this balance. At some point, I might go, maybe this tooth isn't suitable for an onlay. And as I mentioned before, I might then veer towards a vertical preparation crown. So sorry if this is not a definite answer. It's because from a description alone, it's hard to tell for sure. You need photos and x-ray to know exactly how much tooth is missing and how big the defects are.
I would agree. Yeah. Just need more records, but it could go either way.
Yeah.
It could be just restoring cervical and go overlay, or a full crown, just depending on the scenario.
Exactly.
Next one from Joseph Nguyen. When discussing treatment patients, most you would assume will know what a crown or a cap is. How would you discuss this from a health fund perspective in terms of codes and rebates? It's a very specific question, yeah.
Yeah, and a very typical question. Okay. 555 is a direct composite onlay. Is that right, James? So to be
555 is an indirect onlay.
Indirect 5 surface, if I'm not mistaken. Is that right? Okay.
Yeah.
Look, basically, guys.
Indirect composite, you would say. Yes.
Yeah. Two things here. One, all of these full cuspal coverage onlays that we talked about, these are basically a 613. And everybody that I know, they are a 613. They're an indirect they are full cuspal coverage restorations. And if you read the ADA codes, it applies to what we've been talking about. Okay. So these are 613s. So that's the code side of the thing. The second thing is communication with the patient. In the past, I used to do the whole distinguishing. This is what a crown is. Goes down all the way to the gums. This is what an onlay is. It doesn't go all the way down to the gums. This is why this is better than the other one, etc. It just confused patients a lot. They didn't really understand it. I just had patients with blank looks on their faces. Some people were engineers and they understood, but most people, they don't understand. I don't tell them that I'm going to do an onlay versus a crown. I choose for them. So I am the diagnosing clinician. I'm the treating clinician, and they trust me to treat them to the best of my ability. For me, when I talk to patients, I talk about crowns. And crowns, to me, are either a vertical prep crown or a traditional crown, or these onlays or crown lays that we're talking about. They're all crowns to the patient and when I communicate to them. And I think that's very fair. It's not a misleading thing. It's just they're a lay person. They won't understand it. They're not experienced to understand the differences. I don't know. What do you think, James? Do you do it differently or the same?
I think I had a similar early experience trying to explain these things, and most people don't care if you try and describe the onlay or try and describe in detail. So essentially, I will tell patients we're doing a crown to protect your teeth, and sometimes I'll show them I might have some previous examples of an onlay, or if I've never done it before, I will find an internet image and I'll say it will look like this. We'll go halfway down the outside of your tooth, or halfway down the inside. And the only thing they care about is they might notice, they might feel the margin halfway up the lingual. So that's something I would mention to the patient. That's the only difference between that and
Yeah. I've had a handful of patients that over the years have come in specifically asking for onlays or overlays. For some reason, they were quite clued up about it. So there you go.
There you go. Maybe your demographic. I've never been asked that. But yeah, and going back to the communication with 613-555, it's all 613-555. It's typical of the health funds, the major dental, it goes under 613, and then a little bit of 555, you get a bit more rebate. I guess maybe it's my demographic. People care about how much more out of pocket it is. So instead of me telling them, for example, if your crown's $200, it's $200 crown, it's more my presentation of this crown's going to cost you $1,000 versus $200 out of pocket. That's all they might care about. So just keeping that as part of your communication.
Yeah. No, well said. Ultrasonic with or without water? With water. Are we talking? Oh, sorry.
Near the end.
Removal. Always with water. Always with water. You can't use ultrasonic without water because it heats up, and it's not washing the debris out. So ultrasonic with water.
We've had a few thank yous, but we'll go to the next question here. Just wanted to confirm, is it hydrofluoric acid, then trion crown, then phosphoric, then bonding? Okay.
So no, it's you've got your onlay back from the lab. Your tooth is now temporary's come off. It's all clean, sandblasted, so there's no excess cement on the tooth. You do a try-on then. Once you're happy with your try-on, then you get it off, and then you stick it onto a microbrush, and then you go through this step of hydrofluoric acid, phosphoric acid, or ultrasonic bath, and so on. So try on before hydrofluoric acid.
Yeah. Your patient is a Bruxa is going to be the best option.
Maybe. Do you have experience with zirconia onlays, James?
Not very good experience, personally. A lot of them have debonded. Because I think it's the sheer the bond strength between zirconia and the substrate you might make is not as strong as EMAX bond strength to enamel. Even though I do zirconia veneers, that's a different story because the shear strength is not as strong anteriorly compared to posteriorly. If you're doing zirconia crowns, highly polished, without glaze, I'm talking about full crowns, this is quite favorable in terms of wear properties, as equal as enamel in terms of wear rate. So yes, you can probably do zirconia like full crowns in a Bruxa, but you must not put any glaze whatsoever on the occlusal surface. Because once that glaze wears off, the underlying zirconia is quite rough and will damage it will be quite abrasive on the opposing enamel. So
yeah,
highly polished would be the way to go.
So I do zirconia crowns when I do my vertical preparation crowns. They're made of zirconia. That's the best material for it. But for adhesive bonded onlays, I don't have experience with zirconia onlays. I'm not saying they can't be done. Evidence is there about that zirconia can be bonded, certainly. I haven't done it a lot. I have bonded zirconia here and there. But again, lithium disilicate has been so successful. And even in Brox's, it barely breaks, quite frankly, that I'm happy to use it as a first try. And then if it did break, I can then go to an option B, which, gold is still the best. I would trust gold even more than zirconia. So if lithium disilicate didn't work, I might then push the patient towards gold. But then again, I guess if that patient then was super against gold, maybe I would consider zirconia onlay.
I was at a lecture last Friday. Sorry, Bez, I didn't invite you. From Dr. Wally Green, and he was talking about doing just zirconia, like just within enamel only, not even interdenting. So fully enamel bonded zirconia onlays, found very good success. So I suppose from that perspective, if you can manufacture a very thin zirconia onlay purely in enamel, you'll get a very good strength. But myself personally, I have not tried that. I don't know if any labs would do that, because I'm sure he does that chairside rather than send it to a lab. So,
well, that's kind of the idea with even Ivoclar says Emax. You can do them 1 millimeter occlusally. The idea is that becomes fully enamel borne. It's all in enamel. So you're going to have such a good substrate to bond to that the laminating effect, your Emax becomes super strong. I don't know many people who are brave enough to do that. I don't actually know anyone personally that does such thin Emax onlays that are fully enamel.
It's hard to justify. It's hard to find the scenario.
It's very hard.
People have caries or deep fissures into the dentine. Exactly. So it's, unless maybe it's a slight wear case and you're building it up, or OVD increase.
Exactly.
Just thinking out there, but
even in wear cases, you're going to probably be missing quite a bit of the occlusal enamel, so it's going to be denting substrate, a lot of it.
Yes, that's quite hard to might be thinking about foreground instead. Whatever works. Yeah. Very interesting question with for teeth with existing deep subgingival composites, would onlay still be suitable if bleeding is a concern?
Maybe, depending on how deep. Equigingival, slightly subgingival, very easy, no problem. Like I said, you could use cord, you could use electrosurgery, you could use laser. If it becomes a lot more subgingival than that, then what have you got in our toolbox? We've got deep margin elevation, which we haven't talked about. Deep margin elevation basically means doing a really good quality subgingival composite and finishing your margin on composite. There's ample evidence that it works long-term if done well, but it's very difficult to do well. And sadly, I've seen a lot of cases where deep margin elevation has been done and it's not been done well, in which case it's disaster. And in my opinion, out in social media, there's a lot of people that do deep margin elevation under onlays very routinely where they didn't have to. I've seen so many cases where I looked at it and I thought, you could have just put a bit of cord there, or done a tiny bit of gingivectomy, and you could have just finished onto sound 2 structure instead of doing this extra complex deep margin elevation. Anyway, so deep margin elevation, it's not something I do a lot of. I do it in select cases where I think cord or minor bit of electrosurgery or laser doesn't work. On the flip side, if I've got a tooth that's that damaged, where it's very subgingival, that might be a tooth that I might be veering more away from an onlay, because that tooth is already very damaged in all sorts of other ways. So those are the teeth that I might be looking at and thinking, maybe I don't want to do an onlay on this. Maybe this is more suitable, like I said, in my hands for a vertical preparation crown. So there are solutions, but absolutely, as I mentioned, yeah. What do you think, James?
I agree. I think we've been there. I mean,
Hmm.
I had a very short phase where I did a lot of DME, and I still do DME for purely composite plays. If the patient could not afford a crown and was deep, closer than the subgingival, yeah, I'll get my DME band and fantastic. But if the patient will ask for a crown to convert to a crown later on, I'm leaning towards vertical preparation. If there's lots of enamel around the tooth and it's just that one spot where it's deep, I might consider the onlay in that aspect.
Exactly, because you feel like it's a shame to do a full crown prep on this. And those are the cases that I consider maybe I should do a DME here.
Yes.
But it's not very, very common. Less common than I see other people doing.
Yeah, maybe it's just me being like burnt from doing old GIC sandwiches and seeing it washed out. I'm sure it will work out fine, you know, doing the DME as a composite. I just have that innate fear that it could wash out, but probably doesn't.
I should clarify, DME works, but it's hard and easy to get wrong. Okay?
Yes. You don't want to run late. When you're smoothing your prep, how many RPMs with the red band are you going without water?
Anywhere from 5,000 RPM up to 20,000 RPM. But, you know, it's still variable on my foot. So when I put my foot down, it might go to maximum 20,000, but I might lift my foot a bit and the speed drops down a bit. For very delicate areas interproximally, I'm like 5,000. Other areas, buccal and lingual margins, 10 to 20,000. But again, I'm not cutting tooth. It's more like gentle touches and brushing motions, because you've done the vast majority of cutting.
How do you move caries dye? Sometimes still pinkish hues, still present even after repeated washing. Any tips?
I guess it depends on how much pink we're talking about. Is it pink enough that is, you know, damaged, demineralized, or carious dentine? Because if it is that kind of pink, then you might need to remove that pink with a burr, especially if it's, you know, within 2 to 3 millimeters of the DEJ. All right. But if you're talking about a very, very faint pink hue sort of thing, normally a bit of a sandblast afterwards just gets rid of that. It's hard to know exactly how much pink we're talking about. And this does go into a bit of an experience thing. The idea is you should go and read the David Alleman paper on, and Pascal Marnier's paper on caries removal endpoints, and how to use caries detector dye. There is a correct way and a wrong way to use caries detector dye. So it's, you know, it's a big topic to talk all about right now, but basically some pinks you have to remove at the DEJ if it's within 2 to 3 millimeters of the DEJ, but some other pinks you can leave as long as the surface is hard and you're worried that by removing it, you might go into the pulp. And this is all evidence-based, but go read up caries removal endpoints.
There you go, some homework. When you're doing IDS with global comp after reduction, do you worry about the IDS material encroaching on the occlusive reduction required? How do you ensure also there's no bond on the enamel?
So yes, you can, exactly. So if you're going to have a very thin, 0.5 millimeter or less of flowable composite on a surface area there, you might have to prep that area a little bit more to have a little bit of thickness of flowable composite left in that area. Correct. How do you ensure there's no bond on enamel? That's because you do your IDS first, and then you do your refining of the preparation, your smoothing of the preparation. So when I'm doing my smoothing of the preparation using my speed increasing handpiece and red band burrs, I go over all the margins, all the enamel margins. And that way I make sure any bit of bond or flowable composite that was there on the enamel, it's all removed.
Yeah, don't forget when you're reducing, you're going to make room for that IBS layer as well
Right.
as a layer for your bonding material when the crown comes back.
Exactly.
So it's quite a heavy prep. Yeah.
So 1.2 is like the bare minimum for me personally. Like it's more like 1.5 in most areas.
Yeah. Any margin types you prefer for blending?
I found it unpredictable in my hands. I think some people say, very butt margins, which I don't do, very flat preparations, they don't blend in very well. And then the bevel can blend in better. But to be honest with you, it's a bit unpredictable in my hands. James, what do you think?
Same. I'm not an expert. I usually try and bevel, maybe 30 degrees, to also maximize enamel rod exposure on the buckle. And it depends on the material. Like usually I'll try and go for, if I'm thinking about trying to blend, I'll go for a HD, so high translucency, if we're doing a ceramic. So at least it'll show some of the underlining substrate through, and that might help with blending as well. Blending
is not just margin design, it's a lot of things for it to blend successfully. As James said, Emax comes in different types of ingots. You have low translucency, high translucency, medium opacity, and so on. Avoid LT, low translucency. They never blend in. Whereas I find medium opacity, so MT and HT blend in better. But then it also depends on the enamel quality of the remaining tooth. Those enamels that you have, which have a lot of white patchy bits in them, it's almost, you've got no hope of your Emax blending into those white patches. So it can be very difficult depending on the tooth and the features, the internal features of the enamel. So I don't rely on it. Sure. I never promise the patient this is going to blend in.
Yeah, we can't promise that.
We try.
Unless you want to spend some time doing some staining and glazing. You got some extra time. You can try and match the tooth there.
But even then, it's hard. You just can't promise it.
No, you can't.
Really good question. Yes, it can. So it's a very common question. There are cracks and there are cracks. And, if you removed every crack to the ends of the earth, you'd be destroying a lot of teeth unnecessarily. You'd be removing the entire enamel. You'd be removing crack and going subgingivally or going into pulp. You definitely don't need to remove every crack. Some cracks definitely need to be removed. And, off the top of my mind, let's see, cracks that are heavily stained. Because if a crack's heavily stained, that's a wider crack where stuff are going down it, bacteria stains. cracks that are visibly open, and you can see it being open, and you can feel it with a probe. And also those diagonal cracks that kind of undermine a cusp, those you've got to get rid of. However, if you've got a sort of a vertical crack, hairline, very faint, unstained, and you cannot feel it with a probe, leave it. And I've seen 10-year reviews of these, and they stay fine. They don't cause any problems. What do you think, James?
Yeah, I'd rather not chase a crack. I'd rather preserve some enamel if I'm going up to the CEJ. Because once you get deeper and deeper, we're kind of thinning out the circumference of the tooth, you know. So as much as possible, like if the crack kind of stays in the enamel, like if it goes enamel dentine and at superficial, and then I can remove the dentine part, maybe that helps. I'm more comfortable leaving cracks that's just into enamel and not yet into DEJ. But I'm still gonna overlay a crack until take a photo and show the patient. This is just how it is, and at least we've changed the forces from towards compression instead of like flexing of the cusp. And
absolutely,
you know, that's the most important thing.
Yeah. And you know, don't forget that the very fact that we've reduced the cusp height by about 1.5 millimeters or so, that reduction of the height, that's good for the tooth, that because you've got a shorter lever arm. So mechanically, by having shortened it and covered it, that crack is protected. So I'm not worried about the crack propagating and breaking. Yeah.
Yep.
Don't chase.
Yeah, it's also, this is a lot about patient management. You know, really just let them know you've done your best. The tooth might still already be compromised, but this is the best chance we're going to give it.
Exactly.
With the online film.
Exactly. So the one I've got in practice is a GC Universal Flow and GC Universal Injectable I have. Those are the ones that I've got. I've also got a composite heater, so I often heat my flowable composite as well, which makes it even more runny. So I don't know if that helps. But yeah, definitely different brands, different products can have different viscosities.
Yeah, there's different ones out there. I like Majesty. Some others like, there's one from Dentsply where it just self-levels quite well. That's quite expensive. It depends on how you want to use it. Yeah, if you're looking to use it for cementing your onlays, there's some out, I can't remember the names off the top of my head. But even some studies show that even with the flowables, it's still thicker than some of the cements out there, except the one from 3M that's really thin, but I can't remember the name of that one.
I don't know if this, I don't know if they're talking about using flowable for doing resin coating or as a cement. I guess if you're using it for resin coating, if it's a bit thick, just use a probe to run it around to where you want it to be, and you know, hopefully it kind of self levels a bit. If it didn't, then you just use a burr to smooth it and refine it.
Yeah. Probably add more than you think you need.
Yeah.
And you can always refine it afterwards.
Yeah.
I think that's most. I know there were some questions that were repeated, so we skipped those, but I think we've gone through everything. If there's any last minute questions, please put them in now. Otherwise, we will
Yeah.
Thank you, everyone. It's been a nice 2 hours. It was enjoyable.
Thanks for hanging in
with
me, everyone. Thank you very much, Dr. James Tran.
Thank you, Bez. Thank you, everyone, for hanging out. You know, we've got obviously Dr. Bez and myself. We are part of the General Dental Residency workshop program for recent and new grads. Our next intake is for February next year, and I think there's information now on the website. We've modified the program slightly next year, so you can have a look at that. But yeah, seats are open. We've announced, if you've already done a GDR program, I can see some alumni here. We've also announced our implant program tonight, so have a look at that if you haven't started your implant journey. We've also got endo. We've also got a mouth rehab program as well. So have a look at our website for more information. Yes, thank you to everyone as well. So fantastic webinar. So again, have a good night, everyone, and have a good rest of the week.
Thanks very much, everybody. Good night, and thank you very much, James.
Thank you.
I also very quickly mention, if anybody had follow-up questions, please feel free to reach out to me on Instagram, and I'll be very happy to get back to you.
Fantastic. All right. Good night, everyone. Bye-bye.
Thank you. Bye-bye.